Okay, it's 1 o'clock. Thank you very much. Thanks for being here. We will start with a roll call.
Ready? Janine Miller.
She's here.
Jan Gordy.
Present.
Carmel Angelo.
Here.
Bruce Barrett.
Here.
Ross Liberty.
Here.
Lloyd Weir.
Here.
Mark Myrtle.
Here.
Jed Diamond.
Here.
Shannon Riley. Here. Thomas Salmon.
Here.
Donna Getty.
Here.
Okay, Chief March is here, so he's here. All right, item number 2, approval of minutes. Anybody who's read the minutes would like to, Donna.
Yes, I have a couple corrections on page 1. Those present, we need to add Ace Barish and Janine Miller. Under number 2, motion by member Muschetti, seconded, that was seconded by Dr. Barish. And on page 16, paragraph 4, line 4, it should be prevention services. And that's all I have.
All you have.
Are you gonna handle it?
Yes.
Is there anybody who would like to comment?
What was that? Page 16, paragraph 4, line 4.
Yeah,
Preventive
both
service.
outreach and preventative services.
Do they pay you extra to get all this?
Yes,
We
they
did.
do.
Good, I just want to be
I'm
sure
under
that's covered.
contract.
So is that a motion to accept with those corrections?
I move that we accept the August 29th minutes as amended.
Second by Dr. Barish. Any discussion? All in favor? Aye. Any opposed? Hearing none, so carried. Thank you very much. Communication, no last minute communication. Dora, thank you very much. Public expression, thank you very much. You're welcome to discuss any item that's not on the agenda. Please say your name and you have 3 minutes. Ready? Okay, moving on then. Discussion and possible action items. Report on Measure B tax fund expenditure report with discussion and possible action. Member Weir.
Yes. You all should have a worksheet that looks like this. I put this together. We now have some transactions that we can organize. So if you start at the top, this is our Measure B funds, the Mental Health Treatment Act. These are all housed in Fund 1224, Budget Unit 4052, completely separate from the general fund, in its own budget unit. This is a list of the year life to date revenues and expenses so far that the county has received. I start with the revenues first. You can see that we have received April, May, and June's sales tax proceeds from Measure B. And notice on the dates that these run approximately 2 months in arrears. So we did not receive April's until the end of June. We did not receive May's until the end of July. And June's until the end of August. And I'm about ready to receive July's now any day. So we've had 3 months. The total for revenues in 3 months is 1.6 million, a bit over. And then the next section is called expenses, and these are the expenses so far that have been booked against this fund. We have 3 invoices from Lee Kemper for the behavioral health needs assessment, a little bit over $37,000 so far, and 1 charge from the assessor clerk recorder for the election costs. So as of today, the running balance is at 1.4 million, just over $1.4 million.
Okay, any questions for Lloyd? Is there any public comment regarding presentation? Okay, moving
I
on.
do have a question. Was there an additional expense approved by the Board of Supervisors?
We're going to,
Is that on
we're
the
going
separate
to cover
item?
that in the next item.
Okay, it's just not part of this report.
Right.
Got it.
Okay, moving on to item 5, possible action items. B, tracking and monitor Measure B tax funds with discussion possible action. Member Angela.
Thank you, Sheriff. So yesterday on September 25th, we had an item in front of the board that was the Kemper Consulting Group contract. And as you know, the set contract was for $40,000. On September 5th, Mr. Kemper sent the county an invoice, and that invoice was for the agreed upon $40,000. And attached to that invoice was a dollar amount between $24,000 and $28,000. I believe it was like $24,500, something like that. And that was additional charges, actually it was additional costs that Mr. Kemper incurred in the course of doing his work on this assessment. What he had decided is that since the county, he had agreed to $40,000, he was only asking us for $40,000, but he wanted to be certain that we saw that there was additional costs on his part. So I called Mr. Kemper and talked with him and asked him about the additional costs that he incurred, and it really was around additional phone calls, additional meetings, calls with the liaison, calls with me, the data gathering, which took much longer for him than he had anticipated, and then the analysis of the data. And so with all of that said, I said to him that I would bring an item to the board to revise the contract dollar amount to include the approximately $24,500 and also any travel that he would incur coming here to speak with the Board of Supervisors, or if he has to come back to Measure B, I don't know. So I brought an item to the board to increase the contract to $68,000 from $40,000. The board said that they wanted this to go to the Measure B committee, so it is in front of you right now. And the board would like a recommendation from this committee. And again, the facts are that we contracted with Mr. Kemper for a dollar amount of $40,000. He did incur additional costs, and if you know how the process works, particularly here in Mendocino County, when there are so many people involved in this process, he did spend more time on the phone meeting with people. And so we went ahead and made a recommendation to increase the dollar amount to $68,000. And so the reason that I think it's prudent to pay Mr. Kemper is, number one, is Mendocino County pays its bills. If we get a bill, we pay it. And quite honestly, it cost him $68,000 to do this assessment, not $40,000. Additionally, he did the work. And in my opinion, he wrote an exemplary report, and certainly worthy of $68,000, and most likely we started too low with $40,000. And also, if we would like Mr. Kemper to come back at any time in the future and work with us, it would behoove us to pay him what he deserves for the work that he did. So that was my statement to the board yesterday, and I'm bringing it to the Measure B committee for a recommendation to the board. That's it.
Okay, so your recommendation is that we recommend to the Board of Supervisors
That they approve the contract dollar amount up to $68,000. And that includes his additional costs for the work he did, and also travel costs to come and meet with the board next month.
Okay. Discussion. Mark.
So, it was brought to the board without coming to us to spend money out of the Measure B committee. Is that how it went?
That's right. I brought it to the board because I wanted to pay Mr. Kemper, and his contract was up, and it was already a retroactive contract. And if you know anything about the Board of Supervisors, they really frown on retroactive contracts. There was no way to get it to the Measure B committee because of the time span that when he sent us his invoice. So, if the Board of Supervisors rightly so said that they agree that Mr. Kemper did the work, he did an exemplary job, but that it needed to come to the Measure B committee for a recommendation before they would make a decision. And that's why it's here today.
Good.
Just so I understand, is the proposed additional funds that you're asking that he be paid for, is that totally for work that he's already done, or is any of that for anything that he might do by way of meeting with us or anything for the future?
It's for work that he has already done and includes his travel time and his work time for meeting with the Board of Supervisors in October.
Okay. So just another comment and a question. You know, I was appointed by this board to be a liaison with him, and I had, as he described, numerous discussions and back and forth, both questions from this board to him and then him back. So I think he certainly was responsive to us. My understanding, if I understood you right and what I understood from him, was that initially he had said, listen, I agreed to do this for $40,000. I will take $40,000 as we agreed, but I want to let you know I spent extra time. He wasn't, in a sense, demanding that we pay him more than he had agreed to do.
No, absolutely
Exactly,
not.
and what-
He's not demanding the additional.
Exactly, and what I'm understanding is your feeling is that he did a good job. It would be to our advantage to pay him for all the work that he did, including the fact that it cost more than he originally had anticipated.
That's right.
And for me, you know, as a committee member, I would have liked, and I told him this, that if he had done $40,000 worth of work and it looked like it was gonna, he needed to do more work to complete what we had wanted, I would have liked to have come back to, listen, it's gonna cost more, you know, I wanna let you know, I've done as much as I could do for $40,000. My impression was that he did the extra work in good faith because we also said, we want this to happen expeditiously, we want this to move along, and so I think he was certainly trying to both do the work as asked, to do it competently and completely, even if that meant doing extra, and the fact that he was willing to accept $40,000 even though he did the $28,000 additional work, I think that's to his honesty and integrity, and I agree with you that it would be I would support your recommendation to pay him the full fee that he worked for.
Any other committee members like to comment? Ross?
So we get into that position in my line of work, and sometimes, and I watch every penny like I'm like really cheap, and but at the end of the day, I think I agree with Jed that it sounds like, you know, he didn't even ask for the money, right? He's not asking for it, he's just showing, hey, this went over. And the question I tend to ask myself when I'm in this situation in my business is, I say, would I have paid if I would have if the bid was $68,000, would I have gone for it? And if the answer is no, then the question has to be, what would I have gone for? So, but for sure, if we're gonna have a relationship with him or other contractors, we have to have a reputation for being fair. So the question then I think has to become, you know, if the bid came in at $68,000, I mean, we kind of have them over a barrel, so to speak, right now. We don't have to pay any more than 40 grand. But if the question I think we need to ask ourselves, if it came in at 68,000, and would we have gone forward? And I think it is imperative that he did what he did. I think he really has to do what he did. He can't leave this thing halfway through and say, well, I'm sorry I missed my bid, and I'm gonna finish that house halfway and leave the roof off while it rains. And he can't come back to us and wait and ask for a decision, because then it slows the whole process down. So I mean, he did the right thing, but he really pretty much had to do the right thing if he's gonna keep a solvent business. So not making a judgment as to whether or not we would have made that decision at 68,000, but I think that's the logic.
Shannon?
I agree that payment should be made for services rendered. I agree that Lee Kemper did the work. We expressed last month that we're pleased with the report that was produced. I don't completely agree with the process, and I appreciate that the Board of Supervisors routed this request back to this committee where it should have been in the first place. So I would support payment in this case, but I would express strongly that I would prefer to see any additional requests for payment come through this committee first, even if it means calling a special meeting.
Okay. Any other comments from the committee members? Mark?
I'm a general contractor. When you agree to do a project and it goes over, it's usually at the risk of the contractor that does it. That being said, this is a specialty scenario where we really didn't have a lot of other choices going into it. Much like Jed mentioned, if you were going over in the process, the time to ask for the money is prior to you're done, not when you're done. And by the way, it's double what you said it was going to be. So, that being said, I feel a little ominous about giving that extra money because that's substantially more than we agreed to.
Any other committee members? All right, to the public. State your name and you have 3 minutes. Okay, nobody wants to come forward. So is there a motion on the floor? I'm sorry, Jan, do you have something?
I'd like to make a motion to recommend to the Board of Supervisors that we pay the extra cost of Lee Kemper School.
Okay, there's a motion on the floor. Is there a second?
I'll second it.
Second by Janine Miller. Is there any discussion? I have some. Is there any discussion? So the contract, as I understand it, is up, is good through December 31st.
That's right.
And can we, with a motion, and I appreciate the motion, Jan, can we assume that if there was, and with what Jed said, if there was going to be a cost overrun above and beyond the 68, that we would get notified before any of that happened, so there wouldn't be put in another situation? All right, so there's a motion, a second. Any other discussions?
I have another question. Part of this additional services is for a presentation to the board next month, and I don't know
October
what that's
16th.
about. So
Well, when the Kemper report, when Sheriff Ullman did his update to the board, they had requested that, was it possible to meet with Mr. Kemper themselves? And he came and met with Measure B, and so, we can assume that he would go ahead and meet with the board. And so, so we asked him, and we've arranged for him to come on October 16th. And I would encourage the Measure B committee to be at that board meeting as well. And that should be 1:30 in the afternoon on October 16th.
So this would be the same presentation that he gave to the Measure B committee last month?
It will allow the board to ask questions of him. And, they have to deliberate on what they would like to do, with obviously recommendations from the Measure B committee, and then hearing from Mr. Kemper and being able to clarify any questions that they would have.
Ross?
I would assume then that the time for the other visit is not included in the 68,000 because.
No, it is.
Okay.
Yeah. The contract goes through December 31st, and he's coming in October, and the invoice that he sent was approximately $25,000 over, and so we went ahead and made it $28,000 so we could cover his costs for attending the board meeting next month.
Sorry.
Any more discussion? Okay, we have a motion, a second. All in favor?
Aye.
Any opposed? Mark? Okay, moving on.
That's our first
Sheriff.
non-unanimous vote.
Sheriff, I have one more comment on
Yes.
this. That as we all know, our auditor Lloyd Weir is giving us the expenditure reports and tracking the dollars. So when we talk about item B, which is tracking and monitoring Measure B tax funds, it only seems appropriate that the actual monitoring and tracking of the Measure B funds would be with the auditor, not with my office, not with the sheriff's office, not with Health and Human Services, but with the auditor. And so, unless there is some concern from the Measure B committee, that's what I would hope the Measure B committee would agree to.
So in the world of bureaucracy, in the spring, when we go into budget time, are you saying that the budget for the Measure B money would fall under the jurisdiction and responsibility of the auditor?
Well, I think it would be a joint effort, but as far as actually tracking the money and the expenditures, that would be with the auditor. But the decision-making, honestly, has always been you.
Okay.
So it would be the Measure B committee, I think, under your direction.
Right. Okay. Any comments on that? Lloyd?
I'm perfectly okay with that.
That wasn't on the agenda.
Well, it actually was the original item before the $28,000 came up. So
Okay, so
it encompassed both items.
I don't know if we need to do that with a motion and a second, or just we have an agreement that the budget itself and the tracking will fall under the jurisdiction of the auditor.
I think it could just be recorded in the minutes.
Okay. Any public comment on this? Okay, none? Anything more from number B?
No, thank you.
Okay, letter B. Okay, discussion with the Kemper report with possible action. So last month, the Kemper report was presented to us by both in written form and by Lee Kemper himself. We had a discussion about it, and I challenged each commission member to put some thought into this regarding decision, a recommendation to the Board of Supervisors. Our job is very clear to make recommendations that is going to fulfill the wishes of the voting public on the funds that we've collected through Measure B. And I'd like to open it up, and I would hope that every committee member wants to weigh in on this one. If not, just remain silent, but I'm just going to go down the table and ask people if they'd like to comment on the Lee Kemper report, and specifically, Lee Kemper laid out what we need, not specifically where we need it, but what we need. And our committee makes up a very diverse portion of our county, and I think that every member here can weigh in with something a little different than the rest of us at the table. So we always start with Janine, so I won't start with Janine, I promise. I'd like for Donna to weigh in on the...
I don't like you anymore.
Oh, is that a motion?
Yeah, that's a motion. I did read the Kemper report. I think it's a good report. As a family member, etc., I think we need a complete, well-functioning mental health system around the PUF unit so that the PUF unit can function efficiently. We need preventative care, we need respite care, we need de-escalation care, and we certainly need aftercare for an efficient and effective PUF unit. So I personally think everything needs to come together, and it has to function well, and it has to be complete. And I'm just going to leave that right there, and then I'll speak later if I hear something else.
Okay. Yeah.
Okay. So, yeah, I have spent a considerable amount of time reviewing the report, and I'm not an insider of the mental health business here, so this took some learning. I have a tremendous amount of respect for the research that Lee Kemper did, the report as it's presented. I also have some serious concerns about especially some of the estimates for construction for some of these facilities. And I think there's additional exploration that needs to be done on the preventative side of things. I think the need for brick and mortar facilities might be remediated to a certain extent with additional resources spent on preventative, other types of care, as Donna said. So I think I'm certainly not prepared today to make recommendations about spending money on a specific facility. I think we should agree about the prioritization of funding. I think there's more work for this committee to do before we make a recommendation to the Board of Supervisors about a specific facility.
Jed, you're up.
Okay. Well, like we talked last time, and I think was the consensus of the committee, was that the report was a good one. It was comprehensive. As you know, I've worked in the mental health field for 40 plus years, and everything from my experience and what I've learned over the years told me that Kemper knows his business, looked at significant both ways of looking at mental health in terms of that it needs to be comprehensive, that the goal should be to prevent both expensive and long-term residential, that that should be the last resort rather than the first, and that there is a need for a number of priority services that need to get started. So my recommendation would be, or at least my sense of it, is that the recommendation that Mr. Kemper made for the combined CSU and the CRT in Ukiah is a high priority. I think it would be valuable in all the ways that he talked about, specifically that it would solve not all of our problems, but some significant problems of having a place that people could come and be evaluated for emergency psychiatric services. Potentially and hopefully it would be a place that would take some pressure both off of the emergency rooms at the hospital, as well as law enforcement, a place that people could go and be evaluated. And hopefully and potentially would be able to reduce long-term hospitalization. So I would recommend that program be recommended to the board for funding from Measure B money. Secondarily, I think we need some kind of crisis or some type of long-term psychiatric residential services. And from what I got in the report, there were two potential types or ways we could provide those services. One type would be within an existing hospital system. So we talked about the potential of either the hospital in Ukiah or the hospital in Willits to have some interest to expand beds to make them available for psychiatric residential and to look into that. So that was a recommendation. I think that's a good thing to do. The other way to do it would be to have or build either a PUF type unit from scratch or to, I don't know what you call it, retrofit or upgrade the old Howard Hospital as a potential site. But those would be ways of looking to see what would be a recommended site. So I think there's a lot of questions that would have to be answered in order to decide what, where, how, to distinguish between the benefits of adding beds to an existing hospital, whether there would be interest, what that would entail, how many beds, all of those questions, or having a freestanding PUF type unit. So, and I think that's worth doing. I think we need to find out the answers to those questions so that we can move ahead with a inpatient residential service, because I think that's needed as well. So those would be my, as I read it, the first two recommendations that we get started now. But I agree with, what you're saying, that in order to fulfill what I think we all want is better mental health services for the county, I think we need to look at all the ancillary services, because just focusing on those, if we don't focus on the longer range prevention that Donna said, you just said, I think we would be missing out and we would end up with a system that doesn't fulfill all the needs. So that would be my initial thoughts of what I would like to see us recommend to the board.
Okay, Mark?
Reading through the Kemper report again a little more thoroughly. The basis that I felt that the Kemper group really wanted to focus on was the preventative aspect of mental health. And from a utilitarian standpoint, that's definitely where we want to be spending the resources. So when you look at the psychiatric health facility, taking 2/3 of the budget to be at the very end where those are the most critical treatment, I think we want to be spending the majority of our efforts on the substance use disorder treatments and building up from that aspect of things. Preventative treatment and ready-to-go programs to supplement what we have is where I'd like to see our emphasis. I'd like to tread lightly when we're spending millions of dollars and focusing on budgets of millions of dollars, especially with the CSU and the CRTs. We've got 3 explanations of budgets in here where all of them lose money between $300,000 and $500,000. I'd like for us to have a budget that either takes that into account or minimizes that loss before we do agree to spending millions of dollars on it. I'd like for us to reach out to private organizations that may want to take on building a psychiatric health facility and maybe partnering with us with that. But I'd like to see us moving forward with the preventative aspects of things, and I'd like to see that move forward immediately. And substance use disorder treatment, I think, is a big gap, and I think there's a lot of systemic relationship between mental illness and that, so I'd like to see that move forward as a priority.
Thank you. Lloyd?
So my comments were, after reading the report, that we really need to phase our way through this, I think. I don't want to run off and make all the recommendations right away. I really feel like there's more to it than just building the facility. We also have to look at operating it down the line. So I think the first thing is some type of a cost analysis, a study that would measure how much it's going to cost to provide what we feel we need in an ongoing calendar, and kind of mirror that up against what the actual funds we'll have coming in. Because if we're going to move towards construction or expenditures faster than bringing the funds in, we're going to have to look at some kind of loan or borrowing process, which we don't currently have in place. And so I'm not in favor of recommending something solid until we at least see the numbers, or at least I would hope this board would consider looking at the numbers on a year-to-year basis projected out and compare that against our funding sources projected out to see exactly where we're asking the board to go with the expenditures. So as long as that's done first, then I think I feel good about presenting that to the board first. That would be my thought.
Glad you're on this committee. Ross?
So one of the things I got my takeaway from the Kemper report is that he felt that a 50% reduction by prevention, a 50% reduction in clients, patients, whatever, having to go to the PUF unit would be achievable. And I talked to a friend that's a mental health professional, and she was telling me that she thinks if it was really intensive preventative care, that number could be raised to 80%. And I thought about that. I think that if you contemplate that, we could reduce the number of people that need to utilize PUF's kind of treatment services. If you could reduce that number by 80%, and I'm not a mental health professional, I don't know that stuff, but if that's possible, that seems to me that would be a better use of funds than a brick and mortar, because you contemplate those people you're able to keep out of that facility, keep out of a PUF type unit. If you're able to make a difference in their lives, not only would it be potentially more efficient from a fiscal perspective, but also what a huge difference in their lives, right? They're not in a locked up facility. They're actually in a place where they're a productive member of society. And maybe that's not realistic, but at least I'd like to ask that question. So that was one of the things is maybe, and we could do that early, right? That doesn't take years to build. You could start doing that kind of thing early because we have funds, and up to 75%. Measure B money has to be spent on, can be spent on brick and mortar. Doesn't have to be any, realistically. So, I mean, that's a big jump, but thinking outside the box, seeing as how I don't even know where the box is. The other thing, I think before we commit funds to a brick and mortar project, I think that it would be incumbent upon us before we make such a recommendation that we completely understand and we're given a business model, how it's going to work, how the clients are going to benefit from it. Make sure we understand what the costs are going to be. I cannot imagine spending, being from the private sector, I cannot imagine spending millions of dollars on, or tens of millions of dollars on a brick and mortar facility without totally understanding how it's going to operate first. And I personally could not make such a commitment without that. And there's a missing data point I'm hoping that you're going to touch on, and seeing how you know more about it than I do. But Adventist Health is interested in building a PUF unit, right?
No, psych hospital.
Psych hospital. And that might be a different way to look at this. This was a data point I don't think Lee Kemper enjoyed. Right? He didn't have that.
Well, he actually did mention it. He did mention it.
I read it twice.
Well, I don't know if it's in the report.
Anything more, Ross?
That's it.
All right, stop.
So, I don't think Adventist Health means to be confounding, and we've gone back a number of years, Neil and I, looking at the possibility of a PUF unit or a psych hospital, and went back and forth, and Adventist Health has a partner that they work with called Universal Health Services that provides mental health services and PUF units and psych hospitals in just about every state. The only problem is that we've had a bad experience already with Ortner, that they pick and choose their patients, and we just can't afford to do that in Mendocino County. We have to be able to take the worst of the worst, and regardless of payment. And so that's one thing we have to be very careful of. I think there's more deliberation to be done regarding the PUF versus psych hospital. I think eventually we'll need it. I think another consideration, I agree with being deliberative, but at the same time, it has to be recognized that there's a lot of money being spent now in terms of boarding people in the emergency departments and keeping the sheriff's department busy with mental health patients. It would be very nice to have a facility that could unload that for now. And I agree with infrastructure and services to be provided. I read some studies between now and the last meeting. I should probably send what I've read to all of the members. But there are compelling cases for, they've done studies ever since they closed the psychiatric campuses all over the country, Reagan. And it seems like the prevailing best practice is a crisis residential and crisis stabilization as a way of coming upstream of the psych versus PUF unit, and yet being able to deal with crisis that would unload our resources. And so I stated my preference in terms of the next item E, where I would recommend that we move forward on a project to build crisis stabilization, crisis residential treatment to get started because of the overloading that's happened. I think that it's not in anybody's best interest to have these patients boarding in emergency departments and in the jail. And so to have a psych facility that's able to manage crisis, I think is in our best interest. So that's why I made that motion. At any rate, and Dr. Trotter is planning to come and speak to that as well. So that's my thought coming from the report. And I also asked Mr. Kemper at the last meeting if he would agree with that as a priority in moving forward, and he did in that motion. That's all.
All right, Carmen.
Towards the end of Mr. Kemper's report, he says, as the part of this, we believe policymakers should establish a policy goal of Measure B funding is to reduce the need for inpatient psychiatric care while simultaneously assuring that inpatient psychiatric care is available in the county when needed. And I think that's a really good statement. I believe that he's talked to us really about having a golden opportunity because we have money. We actually have money for a mental health system that we know at many times we have considered broken. So part of that, he's talked about the crisis stabilization unit, the residential treatment, regional services, and money to support all these services, which basically are the community-based organizations out there that we know struggle day to day. So I would like to see us really look at moving forward with a crisis stabilization and a crisis residential treatment center. And also, everything we do, and I can say this, that most of what I do is Ukiah-centric. And I think that that's probably a lot of county services. And we have an opportunity to infuse money in the outlying areas and have better regional services. And so I think that if we look at infusing money into regional services, crisis stabilization, crisis residential, those support services, that we have an opportunity to actually have a 24-hour psychiatric unit, a PUF, whatever you want to call it, that could actually be successful, as compared to not having any of these services and building a PUF, and that's all we get. So it's got to be part of the larger system. Thank you.
Ken.
So the Behavioral Health Board has had 3 consultations on this report. We've had 2 study sessions, and we spent an hour in our last board meeting. So we have some notes here from the first study session, if you'd like to see them. Also, there's notes on different types of facilities, because it's so confusing, to me anyway, about what we're talking
Are
about.
there enough available to the public on these?
If not, we'll get more copies. Kemper made 3 types of recommendations. One was services, one was policy, one was finances, and then some recommendations for action. And so most of the consultation that we have done is on program services, which is this paper. The first 1, 2, 3 things were about facilities. And what we have to say about facilities is we get one chance to do right. And we don't want Mendocino County to screw that again. So it'd be really nice if we took some time to do research. I mean, it took Kemper, 5 months to put this together, and who knows how many hours to write up his report. So making a decision in 10 minutes would be really, I think, a mistake. I think we need to do research on facilities and perhaps even visit some facilities. Has anybody on this board ever visited a facility who didn't have a family member in it? There we go, yeah. And I know people around, right? But, so then, like, our auditor said, if we build things now, what are we gonna take out a loan and pay interest on that either? I find that objectionable. I know there's a lot of concern. We have a staff member, a hospital staff member on our board who's like, we need it now, we need to get these people out of the ER, and I understand that, but still, even if we build something that won't happen next week, it's gonna take time to construct it. So we need to know what we're doing. We could set a portable up in a, probably the least amount of time on a hospital grounds if they were willing. But we probably don't have the money for that today. So some of the ideas that we had for service that could happen right away were to expand the mobile outreach program. Right, currently there's 3 units, and only one of them has a team with mental health and law enforcement. So if we had complete teams with law enforcement on each of them and increase the number of teams, that would expand service in more outlying areas. Another idea was to combine or expand some resources that already exist in the county in outlying areas. I know they told me that there's 10 communities with family resource centers. And the more we got into that, the more confusing it was about how flexible that is and where it is and who's being served. But anyway, it seemed like something to pursue an investigation. The other thing that we came up with, number 6 on the thing, is where it says expand support programs and wellness efforts. And we immediately came up against the wall in our board of, what do you mean by wellness? So we need a common definition of what wellness is, because it means different things to different communities and different agencies. One of the ideas was to have workshops for employers and physicians to educate them on mental illness and reduce the stigma that's involved that permeates service in existing channels. And then it kind of got bogged down because it's so dense, it's so hard to understand that people's brains kind of get fried after a while. Regarding day treatment, we don't have day treatment, Kemper said, and there was some discussion about it. So we need a definition of what we mean by day treatment. We do have some programs in some of the existing subcontractors, but we don't have licensed day treatment that's supervised by a medical doctor for outpatient care. So I really think that we need to be careful and take our time and perhaps form committees to do the different aspects of what's needed. And I think, do research and learn more, because it's really complicated and we get one
I just make a, Jan, thank you for this for us, and maybe you could just say what the board is for people that don't know what the behavioral health
The
board is.
Behavioral Health
And
Advisory
get an idea of who
Sorry.
is recommending this and who you're representing.
So I represent the Behavioral Health Advisory Board for Mendocino County. It's a board that's mandated by the state because of the Mental Health Services Act, which is also known as the Millionaire's Tax. So one other comment that came up in our committee, and there's also paper here regarding the same issue, and that there be service at the Mendocino Coast Hospital. Some of our board members are from the coast, and they were pretty adamant that there be some kind of crisis of, what do you call it, support, crisis, stabilization.
Stabilization.
Yeah.
Any more? All right, Janine.
All right. So hopefully I won't lose my voice. So when I read through Lee Kemper's report, coming from just being the behavioral health director, working in mental health for Mendocino County for 11 years, and being a family member, there was a lot of things that rang true to me about what would help our system. There has been a movement in the state of California and across a lot of the country to move towards more crisis residential options. One, because it reduces hospitalization, it's an alternative, it reduces the impact on hospital ERs and incarceration, so you're not unnecessarily incarcerating individuals. We, in behavioral health, had already moved towards doing a crisis residential treatment process. We applied for an SB 82 grant and were awarded $500,000 to start the process to build a crisis residential treatment. That process is what Redwood Community Services will talk a little bit about to you guys later in the agenda. Because we thought it was one of the first steps of putting a process in place to reduce inpatient hospitalization. Anybody who's worked in the mental health field or has family members know that an inpatient facility is really, now I'm not saying that we don't need it, and I think that it's important for clients, it's the last step. A lot of times they feel like failure once they've gotten to that point that they have to be hospitalized. And so for me, I look at it as what are the prevention services that we bring, right? Because we all don't want to be hospitalized. That's the last step. Even when we look at where would we want to be, we want to be helped up front. And if we can't be helped, what's the next step, right? So for me, a crisis residential, crisis stabilization is very important. I agree with Lee on that some of the first steps are. We have sort of a groundbreaking of being able to do a crisis residential. It's something that's been in the planning for this county for a couple of years. We have also, had it in our Mental Health Services Act plan to have some additional funding to go towards a residential treatment facility. So I really am on board with Lee's recommendation that for me, those are some of the first steps. I think it will reduce hospitalization. It's a more positive outcome for individuals, and it's going to really help the community as a whole. I also really like Lee's, we do need to increase the supportive services, have more prevention services, and some housing options. One of the things we know clients will continue to fail if they don't have housing. You can't put a client on the street with their medication and expect them to be able to take them regularly what they need with no alternatives for housing. And as I spoke with Lee about, and still think, we need an option for conservatorships in our communities so that we're bringing clients home and that they're able to live in our community and not having to be moved out of our community. So I'm really on board with Lee's recommendation. I would like to see us move to be able to do a CRT and a CSU, and those are my first priorities.
I've spent 34 years in law enforcement, and I think that what prompted me into pushing Measure A, G, and H, and then ultimately Measure B, was the lack of a PUF unit in this county for the purpose of our society has either intentionally or unintentionally put law enforcement officers, they've changed the paradigm from mental health workers taking care of mental health patients and victims to the emergency responders of putting law enforcement officers as the initial victim or initial responders. And so when we see these tragedies on TV of law enforcement using lethal force against someone who's mentally ill is certainly is a reason to prompt a community to say we can do better, and I think we can do better. And while the Kemper report not shies away, but urges us to look at the preventative, as you know, when you have an auditor talking about preventative services being most important, that rings true. I agree with that. However, the reality of a crisis happening at any time in this county with a person who's never experienced any kind of mental trauma exists, and it happens every day. And law enforcement responds. Law enforcement certainly uses hours in our response, and we transport the 3 police departments and Highway Patrol and the Sheriff's Office transport to the emergency departments. And that was a catalyst for hoping to improve the mental health services in Mendocino County. So if this county says that the crisis stabilization and crisis residential is the way to go, without prioritizing a psychiatric health facility, then in my opinion, we are going against the voters' intent. Because the voters, when I was collecting signatures, the voters were very strong of asking, why do our mental health victims have to be transported to Yuba County or Sacramento or Redding or Vallejo to receive treatment where their families can't see them, they can't wear their own clothes, and when they're released from there, they're not going to see the doctors that were initially treating them. What I'm saying, and I'll be very clear, is I believe it would be easier to go crisis stabilization and crisis residential than it would be to take the hard road of figuring out a way to make a psychiatric health facility that works in this county. And while I don't have my MBA, I believe there could be a business plan to include other counties like Lake, who have even less than what we have. Humboldt, they're a very fragile system. And I would support some type of business plan to see would a psychiatric health facility work. Law enforcement officers are the most expensive government employees we have as a whole. You can pick and choose some more expensive ones as individuals, but as a whole, the law enforcement officer is the most expensive employee we have out there for liability purposes, for training purposes, for salary, for benefits, for the services that they deliver. And Jan, I certainly appreciated the words you came back from behavioral health regarding the coast, because we have to do something for the coast. 24.5% of all 5150s originate on the coast. And we have to do better than that, not just for the financial part of it, but for the human aspect of it, of these are human beings. And whether it's the hospitals, and I know that there's some hospital people here today, and when we open this public comment, I hope that we're going to have some people make some good suggestions. But we need to get to a point where we can ask the Board of Supervisors to move forward. So, as Jed said, it's not going to take, I don't want this to be 5 years down the road. I want us to have a 24-month plan to say, in 2019 or 2020, are we going to have something in this county that's going to be delivering services to people who need it, in addition to the mobile services that we're offering right now. The families of the victims should be heard. Patients, victims, inmates, clients, the word unfortunately is interchangeable. And I'm hoping that we're going to have families tell us, we need a psychiatric health facility here, not just for the business sense, but for the family sense. So to the listening public, to the watching public, you've heard 11 people who are all members of our community give their perspective. And I think each perspective has valid points. And when we talk about as Jan was talking about how hard it is to get to where we need to get, what we're saying is, even if we have money, this is not an easy solution. Think of that. Even if we have the money, this is not something that an expert's going to come in and say, this is a perfect solution. things we need to look at. You know, if a hospital says, gosh, we can dedicate 5 beds, 10 beds, or we can build a bed, then I'd say, well, with Old Howard Hospital, the concerns that the neighbors have of no fencing and no security and so forth, it would be the same at any hospital as it would at Old Howard Hospital. I don't think that we have any hospitals that want to build fences around a primary care hospital. There's a lot of things that come into play here. So I appreciate your candor, all 10 of you who have spoken today. Thank you. Because this is where we need to go. And I hope by the end of today's meeting, we can come up with some recommendation to the Board of Supervisors, whether it's to increase our mobile systems, maybe, or it's to go out to RFP to find out who can deliver a final product to us. Well, but this commission has been seated for the purpose of taking action. And September is a month to take action. We're going to do it. So please think about this. As we hear the public comments, which I hope there's many of, think about where we need to go on this one so we can take a step forward and instead of either taking a step back or stagnating. So to the public, I would welcome your comments. You have 3 minutes, and we are not on a time schedule. Who wants to start? So just state your name, please.
I'm from the coast. My name is John Fremont. Many years ago, well, first of all, there's a close relationship between mental illness and homelessness. And if we can combine those and solve the problems, I think we would be very proud. Now, many years ago, we started a homeless shelter at the Holmes Lumber Yard in Fort Bragg. And what we did was the homeless people who were living there became the board of directors. And we oversaw them, but they took such pride, they passed rules that were rather draconian. No smoking, no drinking, no this or that. But through it all, it was caring for one another. And when you have people who care for one another, incidents of mental illness outbreak becomes modified. So many places around the country have these pods, very low cost housing, either individual units or else apartment, and free housing for mental health professional coming from out of the county, because we know what the housing problem is like. So try to think of it together, homelessness and mental illness. Thank you.
Thank you. You have to start with you. Please state your name.
Josephine Silva. I'm from Willits. I've gone to Crestwood in Eureka, gone to Yuba City several times, not me personally, to be there, family member. Oh, and Crestwood in San Jose. In all of these places, each doctor changes the medication. And then my family member would come back and be on it for a while and then decide, oh no, this isn't, I don't want this. And would lie and whatever and wouldn't take it, and then soon there'd be another hospitalization. Now this is like $100,000 to you each time because there's services and anyhow. Crisis treatment centers with each one. And then as soon as it's possible, it's not working anymore. It's a long trek for me. It's a painful, painful thing to see someone's life go by. And I really want to congratulate my son for the courage he's had. And at this point, he's able to live alone and drive a car. And I'm thankful for that and for all the help that's been along the way and for some wonderful help that's been from the county. But that doesn't change the fact that this is going to continue unless we have some other means of prevention besides putting pills out. It simply isn't the only way. There has to be a lot of not only mobile outreach, but social counselors. No one wants to go to a bunch of services that are only for those who are mentally ill. They want to start their own process of becoming part of the community. And how we help them do that is not easy because it means an individual program for each person. So I'm actually advocating for a hospital situation as a way to reduce it. One more quick comment. I see a hospital in Willits as an economic boom for the town of Willits, and we are hurting there and need it. Thank you.
Thank you. Next.
I'm Betty Cook, 31-year employee of the local hospital, and I know the issues and the problems that the people that are brought in by the sheriff, the police department, I know what it causes for both Howard Hospital and Ukiah. And I agree with Tom that I voted for this because I expected a puppy or a facility of some sort to be built. And I think there will be grave disappointment if that doesn't happen. I think people that come in, people are talking about let's do something up front first. You don't know that guy that's going to show up at the hospital because he's not coming into you. He's not coming in for help. He's in crisis and he needs that kind of help. So anyway, I hope that you will consider that.
Hi there, I'm Jason Wells. I serve as the president of Howard Memorial Hospital up in Willis, California, and on the executive team with Adventist Health in the Northern California region. I just spoke with my boss, Jeff Eller, who is the president of the 8 hospitals in Northern Cal, and he's absolutely committed to being a part of this process in whatever way this committee sees fit. It's one of the biggest challenges we face in our hospitals are patients in our EDs, and we are not necessarily equipped to have a 4, 5, 6 day length of stay with a patient that has nowhere else to go. And we've got nurses who aren't trained in combat that have very, very difficult situations. It's just not safe for the patient, not safe for our nurses. And so finding beds and finding locations that are best for these patients is just critical for all of us. We operate more behavioral health beds than any health system, I think, and certainly Northern California. It's a difficult environment to be in. You want to keep your hospital open. You want to keep employing people, and little hospitals are shutting down all over the country. Most of the health systems in California have gotten out of this space, but we still have Vallejo, a whole hospital, 68-bed facility Adventist Health runs in Vallejo, and I think we have over 30 beds in St. Helena that we still operate. But every month we turn away over 200 patients a month just at St. Helena that we could if we had the beds and had the ability to care for them. As you know, one of the challenges, the reimbursement is just not there, and so it's a very challenging. And so I understand other health systems and their decision to go a different direction. I think Adventist Health is committed to being in this space. If we're going to take care of the whole person, this is part of it. We can't pick and choose. Well, we'll do cardiac and endocrinology, but we're not going to do this. This is something we've got to be in, and so we're committed to being a part of this process, and whatever that might look, whether it's responding to an RFP, whether it's being a part of a subcommittee to explore a facility here. I know at Howard we could specifically by statute have 10 beds. We're allowed as a critical access hospital, you have to be capped at 25, but we could have 10 additional psychiatric beds and still stay within our critical access status. Ukiah has more flexibility from a bed count, But again, it comes down to a decision with this team and what type of partnership could we explore to make this so it's economically feasible. And we know that we need to be part of that solution. So crisis stabilization has been seen as a very successful first step. When you look at what Santa Rosa's done and other places, that's a good option. And I know there's some options out there. And thankfully, the sheriff and others had vision to go after a big enough pool of money to really attack this from all sides. And so, I believe that crisis stabilization would be a very natural first step in really helping some of these 5150 patients that are dear community members to all of us get in the right location right off, help our EDs out as we look towards a longer term solution. The Ukiahs started their ED transformation, I believe, over 6 years ago. And challenging with OSHPOD, it can take over 6 years, as you've seen with just the renovations of their ED and that expansion. We would love for that to go quicker. But if I was to sit here and we were to decide, hey, at Howard's a great location, let's put 10 psychiatric beds, it would probably be 6 years from now before we have OSHPOD signing off on that and have our first patient cared for. That's their issue, not ours, but we are trying to move things quicker. I just know from experience of how long it took to build Howard, the new Howard Hospital. That was a $65 million project, and I know that with Ukiah's, we just did, that was a 6-year project to get that. But we want to be a part of the process, and thank you for listening.
Anybody else want to comment? State your name.
Hi, I'm Mika Ferretta. I'm actually on the Behavioral Health Advisory Board, but I just wanted to actually speak as a member of the community. Although I do want to say in the Kemper report, there is a lot in there, and as a Behavioral Health Board member, those services that he talks about, we deal with on a monthly basis. So I just wanted to assure this board that our board oversees a lot of those support systems that are in place. So you don't have to necessarily learn every single aspect of the mental health services. We are mandated by California. I wanted to say something about where we decide to put this facility. I personally would actually really like it if we took the old Howard Hospital site off the table. And the reason I want to say this is because I feel like it changes the conversation from where mental health clients should be served to who our mental health clients are. So I'm not opposed to it being in Willits. I just think that when we start to talk about the old Willits Hospital, it changes the conversation. So let's talk about where a good place is for us to serve mental health people in crisis. One of the things in the Kemper report I wanted to remind you guys as well is that the mental health system in Mendocino County, the way I look at it is that it's a system in repair, and we're doing that with Janine Miller and with Camille Schrader from Redwood Quality Management. So I don't want us to go in this as we're trying to fix it. We are in a system that we're repairing. Also, I think that the point that people are making about how Measure B money should be spent as far as a voter, I do know a little bit about the mental health system, and when I voted for it, I thought I was voting for some sort of crisis facility. So I want to just remind people that as community members, my point is to try and help reduce conflict over what we're doing, and I think the voters did vote for some sort of crisis center in that when they were voting for it. Also, the facility would need to accept Medi-Cal and private insurance, which I did only learn from being on the Behavioral Health Board. So I think that that's something to look at. And my other point is that even with the best system, we are going to have people in crisis. And that's, I want to have a robust mental health system, but we're not going to avoid having people in crisis, I don't think. And then a couple of main points that I keep hearing from being on the board and hearing here is that the coast needs something. The new one that I heard was that the new a hospital would be willing to partner with this, which I think is a great idea. We also hear a lot about housing, and the point about substance use treatment, money going there and having a phased approach is pretty much sort of what we continue to hear over and over. So I just wanted to make those points. Thanks.
Thank you. Who else? Anybody else want to comment? Okay, back to the commission then. This has been a discussion report. Is there anybody who would like to take action? I know we have another item E where there may be action taken. Is there anybody who would like to take action on this?
I'd just like to make a comment.
Okay.
I think I would like to see action taken today. I would like to hear from the two items that are still to come. Item D, Janine Miller's sharing, and then item E from Camille, discussion of Redwood quality management. I think that would, their input, I think, would help me and hopefully the other committee members be in a better position to make a recommendation.
All right, so we can look at item D and E. One of the things that Jan brought up was the mobile outreach team, and if you remember, or as we know, Measure B does 25% of the funding immediately goes towards improving services, and increasing the number of mobile services obviously costs money, and there is money coming in. And I'm wondering if there's anybody who would like to make a recommendation to the board that some of the Measure B money could be expended to increase the number of mobile teams out there for the purpose of doing the preventative services that's happening. If not, we can put it on the agenda for next month, and I'll, Jan?
Well, I think it would be a quick way to take action. I'm just not sure what you need to say.
Janine, as the mental health director, would you like to weigh in on this?
I think that mobile outreach has been a very beneficial program. I think it has really expanded services to our outreach, but what I would say is that for me, I would want to know what the cost is, and I don't have it in my head today, and I don't want to say we don't take an action on it. I don't think it's as expensive as some of the other things we're looking at, but I also can't tell you today, sitting here, this is how much money we're saying we're going to do. If we expend 2 more teams, I can't today sit here and tell you how much additional dollars, what additional dollars will that be.
So for the October agenda, would you and I would be comfortable in talking about the cost of the vehicle and the employees to increase our number of mobile outreach teams?
Sure.
And it'll be, yes, Doctor.
I would like a little bit more presentation about what these constitute. You know, my understanding is that there's a deputy and a mental health worker that go to clients who are incarcerated and released from the jail in outlying communities. You know, but I don't know the whole story, but
Okay.
I would like to be filled in on it.
And that was exactly it, but I understand your point, so next month we'll give a full presentation on it. It'll be on the agenda. Okay, yes, Jan.
I would also like to know exactly what Howard Hospital is willing to do as a collaborative effort. I mean, our presenters said that they were very interested, but what does that mean, you know? How much money are you guys gonna So is there some way that we can research that, or have a committee or something?
We could certainly do an ad hoc with the hospital or anybody else who's interested. And we could put, sorry, Dr. Barish.
It's fine.
I'm looking at Mark, but he's not looking at me. Okay. So we could do a small ad hoc with Howard Hospital to get an idea of what is on the table. Okay. And there'll be a report, there'll be an agenda item next month on this.
Is that
I'll leave it up
something
to you to figure out your meeting times and so forth.
You'll put the agenda on automatically, or?
Yes,
Yes, okay.
Dora just did it.
Does Janine need to be part of that?
On what there is to offer, if she wants to be, if you want to be,
I can be if you can.
okay? I'll take a can as a one and say, okay. All right. All right, any more on item D? Because we'll move, or C, we're moving on to D. All right, presentation of current funding streams spent on inpatient facilities and how they support an inpatient facility in the county. Member Janine Miller.
All right, so what I wanted to do is, there's always confusion about how inpatient facilities kind of work and how they're funded. And so I was asked to give kind of a look at inpatient facilities from the psychiatric hospital look of inpatient facilities. What I don't have today for you, because I think it's also important in our discussion, so I want to preface that, is that crisis stabilization units and crisis residential treatment units can also take Medi-Cal and other insurances that can help fund them. So I don't want it to look like just inpatient is the only option for insurance funding, because I think that can get confused. A CSU can bill for 20 hours out of 24 hours to Medi-Cal, and then crisis residential can bill, I think it's up to 30 days, and it's on a per day rate. So I just don't want that to get overshadowed in that. When I look at inpatient, I think it's important for me to say that it's part of a system of care. So you have to make sure that inpatient really is your part of a system of care. It's usually your last step. It's your highest and your most costly level of care that we provide to any patient. So when we look at inpatient facilities, we're really talking about psychiatric hospitals and psychiatric health facilities, which we always hear called PUF. The real name is psychiatric health facilities, but a lot of us refer to it as PUFs. And I'm trying to be really good with our acronyms because I know that it's new for a lot of individuals. So inpatient facilities can take a variety of funding sources, and we're talking about psych hospitals here and PUFs. They can take Medi-Cal, they can take Medicare, they can take Medi-Medi, private insurance, veterans, and self-pay. When you're looking at self-pay can be two options. It can be client payment, or it can be a county payment. So sometimes if we have a client who has no insurance, the county then has to pay for that individual to be placed in that facility. Those facilities are billed on a daily rate. And the daily rate can be anywhere, depending on the type of facility and your negotiated rate, you're looking at anywhere from probably $800 up to $2,000 a day per individual when they're placed in an inpatient facility. When we're looking at Medi-Cal specifically, and I would say all insurances, the client has to meet medical necessity to go into that facility, and then the insurance only pays while the client meets what they call acuity. And so once the client is no longer acute, the insurance or the Medi-Cal will no longer pay for that individual. And that becomes a discussion between the county and the hospital on how the additional days are going to be paid for. The county can deny to pay for those additional days. It does get kind of an issue, because when you become a county who isn't going to pay for the additional days, now they don't want to keep your individuals any longer. The other big thing when we look at psychiatric facilities is there is a federal code called the Institute for Mental Disease Exclusion, which you hear a lot of people talk about, the IMD exclusion clause. The IMD exclusion says that Medi-Cal dollars cannot be used for any individual that's under the age of 65 to be placed in an Institute for Mental Disease unless it is an inpatient facility, and then they will pay for children under the age of 21. So what that means for us is that if we build a facility that has more than 16 beds, the likelihood that we would not be able to hospitalize that adult population between the ages of 22 and 64 because they would not be able to take Medi-Cal for that population. That is one of the biggest needs, is that specific criteria. It's where we have the least amount of beds in the state of California. So what I wanted to do, how Medi-Cal works is just an understanding. It's a federal financial participation reimbursement, and then a portion is paid out of county realignment dollars. So there's county dollars and then federal financial participation that pays for it. And that's how Medi-Cal looks at it. I went ahead and brought, and there are enough hopefully for the community members also. This just gives you a look of, we hospitalized 645 individuals last year in fiscal year 17 and 18. And it just outlines the type of insurances those individuals had when they came in and they were hospitalized and sort of how their bill was paid. So the payment for the individual is paid by the insurance source to that individual facility. If Mendocino County had an operating PUF or psychiatric hospital, instead of us paying those dollars out, so the county dollars and the federal financial participation dollars would instead would not be going to the outside, out of facility areas. They would be paying the facility here and covering some of the costs for running the facility, because that's how other facilities cover their costs. It's by the number of patients that are hospitalized and keeping their beds filled on a daily basis. So an inpatient facility could increase revenue by taking clients from other counties to fill the vacant beds. As of 2016, California had 32 freestanding psychiatric hospitals, which is what we talk about mainly your PUFs. But there are other facilities that are freestanding that have more than 16 beds, and they would be called more of a psychiatric hospital. But once again, they are then included in the IMD exclusion, which makes it not able to place adults with Medi-Cal in those facilities. We then have 79 psychiatric units which are attached to acute care hospitals, which is what Willits is talking about. It's a psych unit that's attached to an acute care hospital. When you look at the state of California, there are several counties that do not have an inpatient facility. Whether they do not have a PUF facility or a psychiatric facilities, there are several counties that are close to us that don't have inpatient facilities. Those counties include Trinity, Lake, Colusa, Glenn, and Tehama. So they are close facilities. What a lot of freestanding psychiatric hospitals do, they've run it a lot of different ways, but they generally will take out-of-county clients to fill their beds. So you're not dependent just on your own county clients, you're dependent on having negotiations, brokering beds with other facilities so that your beds are always filled one way or another, so that the facility is not losing money on empty beds. Sonoma County does have a psychiatric facility. It is a freestanding facility that has over 16 beds. Therefore, their facility cannot take Medi-Cal for the 22 to 64-year-olds. And so that has limited their ability to place people in their county that have direct Medi-Cal that are in the adult population. So Sonoma County is another county that needs an option for a 16-bed facility. So the point of the presentation was just because people ask, how are they funded? What are the funding sources? How would you fund a PUF if you had to look at it from that perspective? It really is a business model. You have to run it like a business. It's really about keeping your beds filled and negotiating with other counties. So I think that kind of gives you the view of how an inpatient facility is run. It is the most, it's the highest level, and it is the most costly facility that we place individuals in.
So is that this one?
Yes.
It's the one at the top of the sheet.
So, just to reiterate, if you go over 16 bed with a PUF unit, you cannot bill Medi-Cal for 21 to 64-year-olds, correct?
Mm-hmm.
And according to this, they're the majority of our hospitalizations.
Correct.
Okay. Any questions for Janine regarding, any public comment regarding that presentation?
But if you have...
If you could please state your name and you'll have 3 minutes. Thank you.
James Marmon. If you have preventative services, you would reduce those numbers that Janine was talking about that the county is paying for in hospitalizations. So if we had any of these other Kemper recommendations, we really couldn't count on these numbers being there. Thank you.
Thank you. Any other public comment? All right, moving on to the presentation, or letter E, discussion of on the Redwood Quality Management Company, 631 South Orchard Avenue, Ukiah, proposed location for a crisis stabilization unit with possible action. Dr. Barish.
So, first, I said most of what I wanted to say in the two items ago, but just want to add one thing. That the locked facility, either a PUF unit or a psych hospital, or even crisis stabilization, is probably an OSHPD facility. OSHPD is the oversight, the state or federal oversight for building hospitals, and they take a lot of time, and they become more expensive, and you have to build it to OSHPD standards. And as Jason said earlier, it could take as long as 6 years once you make the decision to build a locked facility and then it actually getting done, just because of all the demands. I expressed earlier and say again that we do feel a certain amount of urgency if you see people with mental illness in emergency departments and inpatient where they aren't really trained to deal with psych patients. It's very attractive to, as soon as possible, start getting them to where they can receive treatment as soon as possible, and preferably not out of county. Camille can correct me if I'm wrong, or Dan, but my understanding was we could build a crisis residential treatment, not have it be OSHPD regulated, and as well as the crisis access where the crisis intake is. And in the building that has been envisioned by Camille, and not have that limited by OSHPD, considerably have it up and running in 18 months. The crisis stabilization aspect of it is another matter, and she can speak to that, but I would like to ask Camille to talk about her facility.
Good afternoon, Camille Schrader with, actually I'm speaking on behalf of Redwood Community Services. The agenda says this is a Redwood Poly Management Project, and it's not. Redwood Community Services runs the Crisis Continuum of Care as a subcontractor for Mendocino County, and it is a founding nonprofit, local founding nonprofit in Lake and Mendocino County. So first I wanted to be clear about that. So there's history here that sort of brings us to today, and that is first and foremost, the Board of Supervisors and the Behavioral Health Board asked Mendocino County to respond to an RFP, to respond to a request for proposals for SB 82, which is mental health wellness grant funding for adult crisis residential. History has shown, research shows, it's absolutely, you can look anywhere, many people in this room have been doing research. 1/3 of the clients that need psychiatric inpatient care have been and can be safely diverted if you have a front-end crisis continuum, crisis residential, crisis stabilization, in addition to your crisis access or crisis response unit. So we responded to the SB 82 program for a 10-bed crisis residential. We submitted a proposal for $1.2 million, and our state of California deemed us $500,000. That $500,000 has a clock, and that clock is running. And we've actually had our third extension at this point due to a variety of issues, including who was running crisis over the period of time that this process occurred. So I want to start there, that this is funding that bought the front-end orchard land where we had planned to do the crisis campus. So RCS got involved in this, as I said, because we run the crisis continuum of care for Mendocino County, and immediately upon taking over, taking care of adults, it became very clear that we had to have some sort of a alternative plan to crisis. We currently have anywhere between 5 and 8 clients at any point in time sitting in the emergency rooms. We increased outreach over 18 to 20% overall, and that increased crisis response by 17% just last year. So clearly the need is there, and in many cases we find that some of those clients could be safely diverted if we had either crisis stabilization and a crisis residential. So what we had done, we know Mendocino County, and workforce is very difficult, and leveraging resources so that you're using your dollar in multiple ways is always something we think about. Also, it needs to be Medi-Cal and private insurance certified, so there were certain conditions. What we designed, and Dan will put out the picture and also speak to the physical site because I'm way up over my scope there. So we had actually started the process when we bought when RCS bought the back orchard building, that's our offices in behavioral health, looking at that front land, designed a crisis stabilization, crisis residential, crisis response program. Currently, right now, our crisis response clinic is on Goby Street. That would simply move over into a campus that has all three of these programs, both for leveraging staff, leveraging sort of requirements, and funding to support all three. We looked at, so a good 60% of the crisis assessments that we currently do are done at our crisis clinics, so both on the coast and here. The other 40 are all done at the hospital and involve quite a bit of the time our law enforcement partners. So just to be clear. So crisis stabilization is a 23-hour facility. There is talk, and actually I saw drafted language last week to have the state of California consider that as a 72 facility so that you reach medical necessity and you can draw down the state rate so you're not locked out at 23 hours for 72 hours. So that's being considered at this point. Right now, at this very moment, that doesn't exist. So crisis stabilization would be 23 hours. One of the things we had spoken with DHCS, and this has been going on for 3 years. Ace and I were working on psychiatric options, and Carmel worked on all kinds of issues from the executive office long before Measure B existed, with varying degrees of success. So we were looking at and would also want to explore a waiver where the crisis stabilization unit only had to have its doors open when we had clients in it. We had designed it as a 4-bed. Dan will talk about why. And then there's crisis residential. So crisis stabilization, you have to meet medical necessity, you have to meet the acuity for the entire time you're there, but it is secure. It is, it's a secure facility and it has tons of requirements, but not OSHCAD. We don't have any of those, yeah. So, but it does have some pretty stringent staffing regulations and oversight regulations that you would need to meet that our crisis response clinic and crisis res do not have that same level. It does and would right now at 23 hours, that's $2,829 a client for a 23-hour time period per episode in the crisis stabilization. So times that by the 4 beds, although I doubt in our community it's hard to imagine we actually have 4 that we're sitting there. Who knows? So then there's crisis residential. Crisis residential was a 10-bed. We connected them together so that we could share, especially psychiatry, nurse practitioners, psych tech kinds of experiences. The medical necessity for crisis residential is less severe. They can stay for longer periods of time, up to 90 days. And it's voluntary, it's not a locked facility. And so our idea was that you could support right at the very front end. We have an immediate bricks and mortar and staffing response. They move from the crisis access to crisis stabilization if they need it, or just to crisis residential if they don't. It could accept co-occurring, which is, as you all know, a lot of our problem are the co-occurring disorders. It feels as if, no, this does not solve the need for a psychiatric facility. I think that they're apples and oranges, and I think they both are desperately needed. They do give us a medically necessary, safe response to the crisis for all of our community members that would not otherwise require a locked psychiatric facility for 3 to 30 days. So I can take questions, but also Dan could talk a little bit about the physical site, if you want to.
Okay.
Oh, well, let me give you a little more. So we had done this, we were working on it as a project. We had an opportunity to put it into a CDBG grant application. That meant it was shovel ready. In my opinion, it's not shovel ready by your standards. We definitely would need to go back and take a look at where we were. But we did a tremendous amount of work, submitted that application. It was declined on a technicality, but the work product has been ready, and it was unfortunate that that's how the city first heard about it. So that's where we are. That's the history. It was certainly developed, and the land is sitting there, bought by SB 82 grant funding that we will need to address one way or the other.
You might explain what you mean by the clock is ticking.
The clock, well, the grant, I'm concerned that even the report we just wrote, which basically took a paragraph out of the Kemper report saying we're still discussing and there is a viable plan, may or may not meet the authorities' qualifications of moving forward, and we could have to return the $500,000. We did this as a private nonprofit venture because we wanted to solve the problem of the people that we were experiencing every day. 20% of those people are homeless, unduplicated percent, which means and they also come quite often. and the urgency of law enforcement and the ERs. If Dr. Trotter were here.
Yes, he is, right behind you.
We're literally every week talking about what we're going to do right now until we have an actual permanent option in the ERs. It has definitely, absolutely impacted our emergency and our law enforcement. We are responding within 20 to 30 minutes, so they're not having to sit there the whole time, but if it's an aggressive, out of control client, then our law enforcement people are also involved. So that's what I wanted to say about. Also, yeah, that's it. Anything else?
All right.
Okay,
So we brought these, we weren't sure what the commission would find helpful, but this was stuff that we started working on, as Janine said, over 2 years ago. It's easier to, if you have something to point at and to visualize, so that's what this is, but we're not, it's not trying to come in and sell you anything, we just want you to know what we have been working on. And we actually, a large group of us, including some folks from the Behavioral Health Advisory Board, I think Janine went with us on some of these. We went to a number of facilities and toured. We went to Aurora down in Santa Rosa, which is a psychiatric health facility. We actually went to the Sonoma County Crisis Stabilization Unit. They built a new one, and we met with the team down there, picked their brains, really went through the whole facility, talked about what was working, what wasn't. We went and saw the crisis residential program. A team of us also, along with Adventist Health, went over to Whiteout, a hospital in the city that's doing some innovative things around crisis, and a number of other, we talked with other agencies and programs that are doing crisis services. So this is kind of a distillation of those conversations and tours and thinking about it. And as Camille said, we really felt like this really works if all these sort of separate things got brought together for our county. It might work in other counties when with the number of clients that we have over here, it needed to be integrated. So what you have here is just a rendering of what this facility would look like. There's some glossies around, and then there's floor plans. And I just wanted to explain that so you understand kind of how the flow would work. I'm sorry.
Okay.
So this would be the main floor. And you should have it in front of you on the second page, the drawing that's to the left. So this includes an outpatient for crisis workers who are doing 5150 assessments would be stationed. There would be therapists here, so community clients who are experiencing some sort of crisis emergency could walk in, get services immediately. That's this area around here. Down here in this lower corner that says respite, that's actually the CSU, and there's 4 units there that's connected with a sally port that's secure and confidential for law enforcement or ambulances could come in, could take in a patient or a client that would be able to go directly into the crisis stabilization unit. That would be available for up to 72 hours, and 23 would be paid for with crisis stabilization. But it is connected, so somebody who comes in as just a walk-in could also then go to their, if they needed to be put on a 5150 hold. So that would be where people are still on a hold. And from there, then an ambulance would be able to come and transport them to an inpatient if eventually we have one in county or in the interim to where we take them all over the state currently. If a person who was on a 5150 is able to be stabilized and can come off that and still be safe, they would then be able to come up if they needed to and chose to and needed a little bit further ongoing support to the crisis residential, which would be on the second floor. And that's what this second drawing is. So there's 10 bedrooms here, centralized around actually open courtyard with a kind of an area here where they could gather and talk and drink coffee and whatever they needed to do. As Camille said, it's not locked, but it would be staffed 24/7. There would be some control as to who's in there and who's not, but it's not a locked facility. There would also be kitchen, dining room, activity room, staff room, therapist, nurse sites, and bed sites. The other thing I meant to also to point out that in this first floor, we would have offices for a substance abuse counselor. Also, we talked about having an office where eligibility would also be present, so if somebody's coming in that's not on insurance, they'd be connected right then. We have nursing support staff to help with if there's questions about medications and then to med sports users. So that's just brief. If there's questions on that, anything you want to add that I forgot, Gail? So we just wanted to have you have a sense of the work that we put into this. I might also comment just in terms of the crisis residential. So that also, somebody who's there who deteriorates could then go down and be in our admitted in the crisis stabilization unit, put on hold, pending transportation to the facility. We have had conversations with Dr. Trotter about integrating this, coordinating this with UVMC for meds clearances. Patients that do end up coming in the emergency room could be moved over here, or if they have a medical issue, could then be moved over to the emergency department. But doing those med clearances are also important to getting them admitted to an inpatient facility. They'll accept them once that's done. So, did you want to comment on that? Your step.
Can I have 2 minutes?
Sure. Floor is yours, doctor.
Okay, so if you come in the emergency room right now,
Can
we
you
have.
state your name, please?
Oh, Marvin Trotter. Marvin Trotter. You come in the emergency room right now, the first bed on your left as you come in the emergency room is room 1. It is always filled by a mental health patient, always. Bed 2, 80% of the time is filled by a mental health patient. We then have up to 5 or 6 people out of our 11 beds are mental health patients. We had 742 crisis evaluations for mental health patients in our ER last year. 742, 365 times 2, okay. They're only 2.5% of our patients. 2.5% of our patients are mental health patients. It takes 18% of our resources in nursing time. 2.5%, 18%. This is a crucial problem we have to solve. And my view of this is, and I'm not talking about people that are brought in that are drunk and can't walk and that sort of thing. I'm talking about they got a mental health evaluation for 5150. So 2 main categories are, I'm on meth and I'm going to kill myself. Okay. The other is, I'm a psychiatric patient, I've been off my meds, and I'm, gone off the reservation. And what I'd like to see is people stay in the ER for 12 hours, they get medically stabilized, they're not, they're clear, then, we've looked at them, we've started them back on their medications, or given them whatever, time to metabolize some of their amphetamines. But at some point, 12 to 15 hours later, they could go to the crisis stabilization or crisis residential, depending on what the mental health workers deem the safest. But you saw what happened at In-N-Out Burger. If 100 people a day will come to our current ER, I have no idea how many people are going to come into a nice ER. And we just spent $50 million on a nice ER that starts opening next month. And anything we can do, and we're talking about stuff we can do now while this is being built, is going to help us, because you can't have 20% of your beds filled with mental health patients because they require a sitter. We have staff standing next to them. We 9 out of 10 days, we have 2 people 24/7 in the emergency room only to supervise these people so they don't do anything rash while we're trying to take care of the other people. Any questions? Yes?
Yeah, whatever gets recommended by this committee in terms of any kind of facility, whether something like this or residential, is going to take time. And I'm just interested in following up on what you just said is, yeah, is there, what would, if there was something that this committee could recommend to the board, could be approved, that would help things now while anything else is being considered, what would you recommend?
Okay. Nice to you, hi.
Oh, yeah.
You go, Doc.
Okay.
We didn't reverse this.
What I'd like to do now is to find some money to buy the Redwood Valley, what do you call it? You call it Sims, don't you? There's a facility halfway to Redwood Valley near the casino that is now being used by mental health. What I would like to see is what I just described for the meth and the psychiatric patient, that they're stabilized. Nobody's worried about them, but you can't let them go home. But keeping them in an emergency room is a fortune. So I would like to work something out with Camille where the hospital contributes something and this group could buy the house and could hold it for 2 years until this opens and then sell it. You won't lose a dime. That we could do a version of this, a step-down version of this now for UBMC. We see 50% of all of the evaluations in Mendocino County. Willits does 12, Fort Bragg does 25%. But that's what I would like to see now. Could we do some stopgap measure until we can get this in a puff unit?
And what is the VAT? What do you call it?
So,
We're gonna try to.
Dr. Trotter.
I was asked.
I know. So the challenge to SIMS, what we're attempting to do is solve an emergency. It is an emergency. We absolutely have to figure out, while Measure B committee and the Board of Supervisors decide what they're doing, what to do on a short-term level. The idea of having anything that is, I don't want us to get our eye off the ball. In order for us to have crisis residential, there are all kinds of components that need to be in place. Crisis residential will allow us to make a certified facility that allows us to draw down Medi-Cal and private insurance, thus being self-sustainable. There's no question that crisis res can and will. It's $1.445 million a year for 10 people, 365 days a year to be there. Crisis stabilization, we had just built the facility. We were building a facility because we were building it, and we did not know whether our mental health department would want to actually license. We wanted the facility to qualify to code and regulation, but whether our county decided they wanted to actually do a crisis stabilization was up to our county. This was previous to Measure B. This is just us out there trying to solve problems. So just so you know. Sims Lane is an emergency temporary hope for being able to take care of some of these co-occurring clients that are not on 5150 holds, that probably wouldn't necessarily even meet medical necessity after the normal 23-hour. They're coming down, they're
Right.
repeats.
This is
It's more of a
year,
respite,
yeah.
longer term kind of, we would do, it's more, yes, you know what it is? It's this living room.
It's a safe
And actually,
place.
absolutely,
Doesn't-
the coast needs it. When I read this, I'm like, this is what we're talking about doing this kind of thing.
Well,
So,
I'm not sure what you're.
it's called the living room, it's Turning
Somebody
Point.
had it on the table here.
Oh,
I think
okay.
NAMI presented it, it's in your materials.
Did you bring it?
No, it's from the Coast Hospital.
Oh, it's a really good, this is exactly what we're talking about doing. In the short run, using intensive outpatient services, small blip in the contract, there, we can certainly talk about Measure B. I would, so with all due respect to my
No.
lovely Dr. Trotter, we want to stay on task
Yeah.
with what are we doing as a Measure B board. So.
This is the time of prize.
And if it isn't, so I also want to make sure you know, we did this because we needed to solve a problem. If this needed to be, the title turned over to the county and the county had it, and the county did this, if we had the building and somebody else, this is not about RCS doing the program because RCS has done this. We were going to because we're responsible for crisis intervention, and it's killing us what we're having to do with the clients that we see in extreme crisis. So what this board and what the Board of Supervisors decide to do is certainly open for discussion.
And I just want to point out that the SB 82, the $500,000 that we actually bought the piece of ground with is county dollars. So, and you know, the county, we're quite happy to have somebody else take it and run with it.
And one of the questions, at least for me, you said, it sounded like there was a time crisis in, could you say exactly what that is and what the time crunch is?
So we just submitted, I'm looking at our mental health director, we just submitted our last extension letter last week, I think. We gave Karen the information. I don't know whether I don't know what the time limit is. I do know if we actually have a plan and we're moving on it, we have, you know, that it would qualify. But sitting in limbo at this stage, we would need to make a decision.
We have,
The county would need to.
we have given updates. The state asked for an update in order to get this extension. And we did say, well, there's conversations going on within the county about what to do regarding crisis residential. So the state is aware that this is a conversation. They're sort of pending, saying, okay, what's the outcome? And I'm assuming
So far, it's been okay.
it's been okay, but there's a dialogue going on actually with the state on this.
But this is not a PUF unit.
No,
It's crisis stabilization, so I'm wondering why Dr. Trotter would think that this would greatly reduce emergency room.
because they wouldn't have to, well, one, the clock starts when they get to the crisis stabilization, so there's two ways, it absolutely would. So there's two ways in which it could be used. One is they come directly to our crisis stabilization and they're low level or we know that it's meth and the doctor comes over and med releases them and they never ever go to the ER, one. Two, they go there, they're not crisis stabilization and they go into crisis res. The other way is they go to the ER, they get med release, they get stabilized in the ER, and 12 hours later, they get driven over to the crisis stabilization where the clock starts for another 23 hours. So it absolutely could relieve, both the crisis stabilization and the crisis residential will absolutely alleviate a tremendous amount of stress on the crisis, on the front end. And I'm not just saying this, everybody knows this. I mean, everyone's been, if you look at the research, it absolutely shows that. And it doesn't change the fact that there are still 200 clients turned away every month at St. Helena for psych beds. So it really is, it's the very, very front end and a part of the continuum, but it doesn't replace a 30-day psychiatric facility.
But also clarify on this, so you actually enter into the crisis stabilization unit or an emergency department, and that's where the 5150 is reviewed, and upheld, or rescinded, and the attempt is to divert from a psychiatric facility, but that's where it starts, and there's a meds clearance, and that 5150 hold then is sent up to either a psychiatric health facility or a residential hospital bed. So you don't go straight into a PUF, and I guess we could set that up locally, but that's currently how it's functioning. For the ED or crisis stabilization unit does the initial assessment and sort of triages what would be best for this client.
But more importantly, like James said, Mr. Martin, and multiple people, a third of them may not need to go to the psychiatric facility at extreme expense and time. So.
Okay, we have several questions up here, and I'm going to go in the order of they were raised. And Janine Miller.
So I wanted to just kind of piggyback on you asked that question. I think if you look at a CSU, like a mental health emergency room, so it's not exactly like an emergency room, but that's kind of what a CSU is. Instead of going to the emergency room, you're going to your mental health emergency room where you're getting treated there. You're not needing to go to the emergency room unless you have a medical condition or for some other reason. They could actually come into the emergency room and then transfer over. But in most counties that have a CSU, you're brought straight to the CSU. And you do not go to the emergency room. And I know in Sonoma County, what they've really worked is having a doctor in their CSU to actually do some of your medical care in there. And I'm not saying that's what we're looking at here, but there's been movement to do that. So a CSU is more of like that emergency room, but for your mental health needs.
So you indicated that the county paid for the property and it's not about our revenue, right? It's just, so who has the title on the property?
So RCS has the title. We have a lifetime, just like with the homeless shelter, a lifetime use requirement from the county for it to be a crisis campus. That's not unusual. There's lots of private organizations that have agreements with the county on that.
But at any rate, you'd be happy to get that. I mean, that's not, ownership of the thing is not your goal.
Ownership is not our goal.
Okay, got it.
Now, getting it done is our goal, and I have a personal belief that this, no offense to my county partners who I love dearly, we'd like to get it done.
Yeah.
And so private sector tends to have things built.
So, along those lines, so have you got quotes from contractors? Because I think you guys have kind of a budget to put it together, but I don't know.
We did, and again, the shovel-ready project that we submitted for CDBG had basic quotes and a general plan. We would probably want to revisit this. Even just this conversation around, we had 4 beds at the CSU, or we're sure this group wouldn't want to sit. I mean, there's probably some variance that we need to do. For the crisis stabilization, in terms of the utilization of it, we did not drill down. For the crisis res, we did. We know that the program costs, they will be somewhat new cost, so that 1.5 million to run the program for the crisis res. Probably somewhere around 30 to 40% of that are probably current costs being spent in intensive outpatient that might crosswalk, but it does have some new costs in it. The CSU would be new costs.
It does draw down federal 50%,
At least.
50 on the dollar or more is federal share on this, so I guess just that number is, you can actually parse that down a little bit more, so it's not just what it sounds like.
So for the 2,829, that half of that is what the county's share is in order to draw down the FFP for a 23-hour episode per client in the CSU.
Yeah, and there is some money in the Kemper budget for ongoing CSU.
Yes, yeah.
Even after construction, there's some money.
Operations, right.
And then, do you have some sort of, do you put together a business plan kind of thing specific to this?
We have put together a general operations plan. It probably would need to be revised for this purposes, but
Is that something you'd be willing to share with this group?
Sure.
You're not the architect, right?
No, I'm a real scientist.
Okay. You're just the loveliest.
He's the brains of the operation.
All right, Carmel, do you have a question?
I have two. One is, will ambulances take patients to a CSU? And two, at what point do you do a medical clearance? So do you still have to stabilize them on meds and then still take them to the ER for a clearance, or how do you do that?
So we've talked about coordinating with UBMC to do that meds clearance. Most, all psychiatric facilities require meds clearance. They're looking for, is there drugs on board, is there other medical conditions that, and if you're not connected to a hospital, that some places won't take a patient, so they want that. Once you've gotten the med clearance, you have to maintain control. The client can't go outside the building, so that's why it needs to be on an ambulance that pulls into that secure, confidential.
So what we had talked about is both ways. One is they do come, law enforcement or the people bring them in, you have to do the technical med clearance, but you don't think they necessarily need to be in a hospital looked at by an MD. And the other is they go to the hospital, the ER looks at them, clears them, and then they come over.
2 hours straight over.
Right,
Yes.
right.
I'm sorry though, I didn't catch it. Did you say that ambulances will take patients to a
Yes,
CSU?
we have, they bring in, the door closes,
Either from or to, so.
confidential entry. We kind of did it for law enforcement. We did quite a bit of this work with our county partners. We worked closely, and the jail. I think it was Captain Pierce was quite involved in it. This is what we would want.
So do majority of the counties have crisis stabilization units? It would seem that it would be effective. And
So
also
rural counties do have a tough time with, frankly, the whole continuum, including psychiatric facilities. So the general answer is we are a very, very lucky and fortunate county that Measure B has existed. And because we are on this end of rural, we will probably support, if we wanted to, other counties' need for these kinds of things if the community were to want that. Volume, so one of the things that was discussed was maybe 2 beds on the coast for crisis stabilization. And again, the requirements of crisis stabilization are such that maybe we could have the psychiatrist and the nursing that we're responsible for inland health for the post hospital. There may be a way to get to yes on that. In terms of the volume, we built it such that we think it will be able to sustain itself in that respect. Hopefully the state would give us a waiver. I did get initial, hey, that's not a bad idea for a rural waiver to only have the CSU open when a client is in there. If that happens, we'll be much better off. And the second thing I talked to Dina at DHCS about was, one, getting the daily rate for the CSU, and then maybe being able to do some intensive outpatient mental health at the site, because you're still going to have the psychiatrist, you're still going to have the nurse, you're still going to have the site techs, and you have one client in there, for example.
The CSU would pay for itself.
Well, that's why we put them all together, is the hope that as a threesome, it will pay for itself.
Crisis residential, I'm sorry.
And crisis access. So our Gobi Street outpatient clinic right now would move over.
But even 2 or 3 years ago, when we started this conversation, the feedback was a CSU has a really hard time being sustainable all by itself, which is why we pushed at this, But even this, I think Lee Kemper is actually right that building in some ongoing extra support. So a couple of the issues that happen, so you're going to take anybody that comes, so you're going to have folks that don't have Medi-Cal, don't have, or whatever, they're indigent, can't get enrolled. Also, CSU only pays for 23 hours right now, and as Camille said, once you go beyond that, there's no funding. And if you can't get that person into a bed, which is why the PUF is so critical, you're stuck holding this client, which is kind of what's happening at the EDs now. When we are trying to broker a bed, they can be there for 2-3 days, depending on the severity and the conditions and whether that hospital will accept them or not. So,
Which is why we still need a hospital, because.
So that's the financial Achilles heel, is if there's no funding, you still got them.
But even though you're not getting paid, the emergency room is unloaded, which is.
Well, yeah, which means, well, all we
So-
can, no, but
so-
if I were the Measure B committee, that would be my one purpose. So I've said all these benefits, and I absolutely believe it's a benefit to our patients, and I absolutely believe that it will reduce our need for inpatient psychiatric and reduce the repeat offenders.
It's a much bigger cost.
Having said that, if I were sitting where you are, and you're really saying this, we have we've just shifted the burden of that 24th hour onto us that right now is on the hospital.
Right, and that's,
So-
but it's much more expensive for the hospital than for the CSU.
Just to be fair.
So just for the system.
And it's, in a crisis stabilization unit, it's built to treat mental health conditions. It's not about treating a broken leg, it's about supporting the.
And what we talked about with this issue was if they're on a 5150 hold, they're in the crisis stabilization, this was the conversation with Dean at DHCS, they no longer needed to be in a secure locked room, secure, that we could open, the way we built it, you could open the doors, it's now just an outpatient bed hold, and then the lockout for being able to provide outpatient mental health services is waived, and we can serve them while we're waiting for a bed.
I'd just like to point out that the people in the emergency department, not only are they not getting any treatment, but that it's a traumatic experience. To have to sit in the emergency room and be sat by somebody preventing you from leaving without any windows when you're in crisis, and so that's part of it. This is a much better option.
I invite any of you to come by the ER, and I'll be happy to put you in room 1 for 72 hours and see how your mental health is doing.
We'll go to doctor, then we'll go to Janine.
One other thing, I wonder if Wells would like to make a statement just about his opinion.
Oh, I support you guys 100%. This is the solution, the beginning of the solution, the beginning.
Right, Janine Miller.
So just wanted to clarify 3 quick dates. We can only go for 20 hours in the CSU, so I just want to make sure it's not 23, it's 20 hours and 24. So we just want to make sure we're really clear. So we can go for 20 of the 24 hours, that's what Medi-Cal allows. Hopefully private insurance will let us do a little more, that would be nice. And what we're seeing in a lot of the rural communities is crisis respite more than crisis stabilization because they haven't moved to be able to do that. But crisis stabilization gives us a lot more avenues to work with because crisis respite, you can't work with the client that's really in crisis. It's really an after crisis thing. So it's somewhere where they leave the hospital and then you're putting them in. So that's what most rural counties are able to do at this point. So we are very lucky to be in a place where we can actually have a CSU. Most of your medium and large counties are moving to CSUs and CRTs, and most of them have them, which.
So we're doing the analysis right now with, Sarah's the director of our crisis continuum, she's sitting over there in the orange. What percentage of the population that we currently had hospitalized, of that 745 clients, could have been stepped into a crisis residential setting in the 23-hour window? And what percentage at 2 days, and what percentage at 3 days? So we have an answer to Ross's question, which is how much are we, at least from utilization, from what we know in the last 2 years, because we now have data, what's the risk on the CSU side? The residential, it's new funding, but there's no risk.
I just have one more thing. Okay. So I wanted to clarify that as of right now, I'm hearing that ambulance wouldn't be able to drop off at the CSU, so we just want to make some clarity. Our EMS head is letting me know. But there is some legislation.
Oh, wait, so that's contrary to what you just said.
Yeah, it is.
So that isn't what DHCS said.
We probably would need some
We need to do some clarification. That's what I'm saying. We'll want to get some clarification on that. I know there is legislation out there that LA and Orange County is moving to allow. There is some pilot projects that were in work, and there's some legislation to move it. So I want to see where that legislation is right now.
Are there any other Measure B commission members who would like to ask questions of Camille? Mark?
Oh, Dan, I'll turn it back to you.
So, I'd like to see, it sounds like to me we haven't really paid a designer to design the project, that's correct, is that correct?
So I don't
We have a
want that technical
conceptual,
question.
all we have is a
Our-
concept.
RTS has paid, the gentleman, Richard Rupp actually is a local architect that did this. We kind of put a stop on this then when we were able to move forward with the CDG funding that we had. So we probably will use a different architect going forward.
So it is not designed.
So it is designed to the degree that it qualified for CDBG shovel ready. So we're not in your field, so we don't know how to answer that technical question, but we can tell you that it counted as a shovel ready project for CDBG. I don't know how to answer this.
So 30% design.
Okay.
Okay, so that
Thank
means we have 70% more of the expense in the design costs.
In the design.
Right, right. And the design costs typically are around 10%.
Yes. So that's in the budget that we originally
Submitted.
submitted to CDBG, included the finishing engineering and the.
We could bring that budget.
Who provided the budget?
Oh, Richard Ruff initially was the one that we worked with and did our feasibility report to CDBG.
All right,
And
so,
And we could bring that.
if,
yeah, the budget, I think, needs to be one of the primary important things. And then I think the revenue stream needs to be another very important thing. And then I think the costs need to be an important thing. To know, I think we're all in agreement that we want to do this. We want to know what we're getting into, and it could be a negative. I mean, as long as we know that it's a negative and what the negative is going to be. But we just can't go into this and, yeah, I'll feel good and this is great, and then we got a $500,700 negative that nobody's planned for.
So with all due respect, in
Yes.
response to that, we haven't, that's not quite the definition of what we've done for the last couple of years while we attempted. The project that we can bring to you that is as ready as, and it sounds like it qualifies as 30% design ready, is the application that we submitted to CDBG. So we can go through that. Yeah, as I said, I'm sure that there's work we have to do, and frankly, probably even adjustments that this group would want made. Secondly, on the operation side, the CSU was, we were building the physical site for the CSU. We had not, because we're not in charge of whether the county would like to have that service component available. We wanted the physical, because it's expensive to build a physical space. So we can absolutely go back and take a look at the operational costs on the CSU, which is what I just said. We'll look at utilization, we'll look at the numbers of clients that we feel like could do that on the CSU side. On the crisis res, we have it, we run homes that are very, very similar to crisis residential without certified crisis residential.
So you're real close.
We have that.
You're real close.
Yeah,
to that.
and the crisis access center, we already currently run, we already have a budget, we already have a staffing ratio. So the only one we don't have on the operations side is the CSU, and it would have been really presumptuous of us to go down that road without county leadership.
so there's two things I hear you talking about is there's the construction development side of it, the bricks and mortar, and then there's an operational side, the sustainability and furniture and so forth. There's, and we've had conversations with Shannon here in the city, there's a lot of steps that need to happen. We all, we go through the usement process with the city, design review and so forth, their planning department and so forth. So I don't want to sell this as, oh shoot, tomorrow we can turn our building permit application and we're ready to go. So, but we also aren't here to, this is a conversation and we try to let you know where we are at, but there's no hard sell here.
Oh, yeah, I'm just telling you where I feel I'm at, and I think others on this committee is they want to know what they're getting into.
Yeah, so we can bring you the budget that we did for the grant, and that's as far as we've taken it since then, and we can go further. Like, on the physical bricks and mortar side. On the operation side, we have.
The other thing I would add, and I'm sure our architect is okay if I put his name out here, so we have retained, and I have a contract with Ron Verdier has an office in Boonville, so he is our architect at this point, and we have talked, so he's basically up to speed on the project. Haven't actually paid him any dollars to do anything on this, but he's the guy that we'll be working with and his engineers.
Okay, I'm going to ask you, and I'll also ask Jason back, if both entities would be comfortable for next month to give a 15-minute presentation on what you would be able to offer. And you've heard what the problems are. So whether the 10-bed facility or whatever the the Adventists would be able to offer, or was willing to discuss, and the same for Redwood.
So,
Child
Sheriff,
Social
I just want to say they're two different things.
I
They have
get it.
nothing
I
to do
understand.
with each other.
I
So,
totally understand.
I don't know that we have more to
The good news
say.
is, we need both of them.
Okay, I guess my point is, I'm not sure what else we could bring the grant that we wrote and hand it to you in terms of a budget and have a discussion about that if you'd like.
I think
But-
that would be
Perfect.
a good step.
I could do that, okay. Look, I just want good, I don't know what else to say.
Yeah, I just wanted clarification. I think this is what you're saying. I mean, part of what we're charged to do is to, you know, we've all read the Kemper report. We know what's recommended. You've heard from all of us talk about what we think the next steps should be. I think we're at a place, I'll speak for myself, and others can say if it's different, that we're in a position where we are ready to make potentially some recommendations to the Board of Supervisors on what we would recommend that be done next. And so for me, everything I know about what you've proposed is it's a good idea. All the things you said make sense to me. I think what's missing for me is the details of, you know, the costs, all the things that were voiced, so that by next month, potentially, we could make a recommendation to the board saying, here's what we recommend, and we know what we're getting into, which is what, yeah.
And we weren't prepared to
And so if you
do,
could
to do that.
bring
We weren't
whatever
prepared
that,
to
whatever,
the board
you know,
wanted, so, yes.
that would be, so that we
do
can make a, you know, a reasoned recommendation to the board on that. That's what I think we'd ask of you.
So we can bring what we had, and we might even be able to have our architect do a little bit more than we had actually submitted. And whatever answers we have, our experience with our city partners is, that's the answer we have until we all get to a room, and then the answer changes, so.
Well, and to that point, the Kemper report actually explains that there is a need for a fiscal analysis on page, you probably don't have it in front of you, but page 28 of the report actually details 4 different items that should be included in that fiscal analysis. So you may not be able to answer all of those questions at this point, but any attempt to address those, I think, would help satisfy the recommendations in this report, and I think what we're hearing.
Probably do, I agree. CSU, we should probably talk about
28.
Jason.
Sure, would you be open to one presentation from all of the people in this space? Because it is a continuum of care.
Sure.
And I think we could collaborate and with Janine and come up with, this is how we, as all partners who already operate in this space.
That would be better.
This is, yeah, because I'd rather collaborate over the next month. We're gonna spend a lot of time together. But, and bring one proposal.
Okay. October 24th at 1 p.m. here.
We will be ready.
Okay.
And I would love to just, it's an option for you to consider, and you can take it apart, you can accept, you can say, never mind, it's fine. Great.
Okay.
And just to clarify, is Dr.
Conflict
Trotter
extent.
part of that?
Oh, absolutely. So Dr. Ace Barrage is the CMO of Howard. Dr. Trotter is the CMO, Chief Medical Officer at
Good.
Ukiah. Obviously, we both.
RCS.
Yeah, RCS and if any
Right,
county
that would be
support, we would.
helpful.
Okay, any more committee members have questions for now, or can we save them for next month for the presentation? Shannon?
Can next month's presentation also involve a little more information about Sims Lane? Or
Well,
whatever
That's
those other-
probably not,
We're not
that's
ready to do
probably between us and them,
Okay.
not.
Well, I think the
Set
committee,
aside.
if
We can
get
explain it to
together,
you more.
it
it's
may or
an
may not.
informal agreement to solve a problem in the immediate future.
Okay.
So,
Okay.
We're gonna move on to the next agenda item. The next agenda item is, I'm sorry, I did not open this up for public comment. Okay? All right. Is there public comment on it? Mr. Mormon?
James Mormon. I think the committee or the commission is headed in the right direction today after doing everything that's happening. I think a crisis stabilization unit is the first thing that should be looked at. I've had in the past where I transferred 5150 to transport it up to St. Helena and have them almost beat me home. You know, because a lot of people stabilize within that first 24 hours. And there's a lot of data that states that. Now, I don't think it was the will of the voters to build a large facility and treat folks from out of county. Now, some private company like Adventist Helpers, may be into that. I think a partnership on a psych unit with the Adventist or somebody else would be a better move, because there'd be, I think Comfort discussed that, there'd be more options on a long-term financing, different things like that. So that's, anyway, good job.
Any more public comment? State your name, please, Mayor.
Yeah, I'm Bernard Cameron from Willits, and following all this conversation today and understanding that Measure B, although a lot of people from Willits felt very strongly, was primarily for a PUF unit, Measure B quite obviously was for a much broader spectrum that a lot of people feel is important. And when I hear about the plans for this unit here and having all these facilities next to each other, close to each other, and the benefits of all that, maybe I missed this part of it, but can a PUF unit be considered to be part of that package? So partly because of all these plans and all these ideas for Measure B is going to, like Mr. Ullman says, also looking 5 and 10 years down the road, is definitely going to hopefully lower the needs in as many people that would wind up in a PUF unit. So it could be possibly a much smaller building than something like the huge old Howard Hospital. And so I don't know if I missed it, but whether a PUF unit can be part of this conversation that you're all going to have next month.
Thank you. Any other public comment? All right, moving to the last agenda item of the day, I'm sorry, two things. We'll do reports after that. Monthly committee update to the board of supervisors of meeting each month. I give the presentations, and I'm usually followed by Jan. True story. Is there anybody who would like to participate in assisting in giving the presentation to the board of supervisors, other than myself? And I would welcome Jan to be a regular there. Is there anybody else?
You did a great job.
Well, we will continue as it is then. But if you would like to, last minute's okay.
I do have one comment about that. I appreciate you doing the reports. It's probably convenient because you're there, you're used to speaking to the board. I do appreciate that. I would also appreciate not making promises to the board of supervisors about actions that this board may take in advance of our discussions. So there were some comments made at the last meeting that said that we will have recommendations about a facility at the October meeting. And I think we're not quite there yet.
We're not quite there. You're right. Maybe it was just a hope and desire.
Yeah.
Okay, we'll take it. Any other comments? Jan? Yes, by all means.
Well, you wanted to have some kind of action, right?
You did?
So I was thinking, on page 43 of the report, there's some recommendations for policies. That would be an easy action to recommend to the board of supervisors that they adapt the policies that have been recommended. You don't have to spend money to do that.
Adopt the policy?
Yeah, adopt. You said adapt.
Adopt,
Oh, okay.
What page is that down?
It's on page 43, key policy decisions and recommended actions. It says the following policies are recommended to assist Mendocino County in meeting its goal of comprehensive mental health services continuum. Measure B fund should supplement, not supplant, a biannual review process, a prudent reserve, separate annual accounting, 10-year strategic spending plan, and subcontractors restructure the manner in which data is provided, including program by region, which is something that the Behavioral Health Advisory Board has been asking for, is an explanation of what programs are being presented of services, instead of just numbers. Like,
Okay, so you're talking about page 43 itself, and on page 44, the strategic planning.
no, just page 43, the policy recommendation.
Okay, so a possibility would be for this committee to vote to adopt these as our guidelines and
To recommend to the board of supervisors. to adopt those
Yeah,
policies.
yeah, after we, yeah. And so it would be for us, we're gonna recommend them for ourselves and then recommend the board of supervisors, recommend them for continue on. I think that would show a commitment from the board of supervisors that we're gonna follow the rules and we're gonna ask them to follow the rules that have been recommended.
I don't understand why we would do this for ourselves.
Well, we-
Yeah, I think it makes sense to do that, because we're saying that, we think these are good recommendations. We're either adopting or approving them as guidelines to go forward, and then that's what we bring to the board, and we ask the board to approve them as well. Sure.
Is that a motion?
I'm not making a motion.
No,
It does
are you?
include, yeah, direction to some of the service providers though, so I guess I'd be curious to know if the county's comfortable with that direction. Number 6 is direction to the subcontractors and RQMC and behavioral health.
To provide a data report of the.
To restructure the manner in which
Right.
reporting is done.
Yeah, that's the recommendation.
Right.
Because right now it's only about client numbers.
Wow.
So I move that we adopt these policies as recommended by Kemper and recommend them to the Board of Supervisors.
I'll second that.
So motion is second. Is there any question? We have not heard public comment. Now, I want to let you know, Robert Rules of Orders, this specific item was not on our agenda for approving.
Well, you mean it's already
If I could finish, I'm sorry. So we've moved past several items and now we're to the last item. I guess, and we don't have counsel here, but we're not.
I thought that you had postponed 5C until we got through the rest of the reports as far as taking specific action.
Okay, if we want to take it, the worst thing that could happen is someone say that it wasn't right and we'd have to do it again. So we have a motion and a second. Is there any public comment on page 43 of the policies that Kemper recommended? Carol, are you going to comment?
Hi,
Okay.
Carol Hester, hi. Could you do a pause a moment, all of you wonderful, brilliant people who do such hard work? John Q. Public is here saying, what in the world is happening with the measure I voted on? And you've all said, we all wanted a puff unit, all of us here, all of the stuff here. So my suggestion is, and I love the adoption of, that's really a step, somebody's doing something, thank you. Put some PR out there, like every week, do an update, some little tidbit that says, you guys, I know, you know, that if people want to watch the board's meetings, that's what I do at night, so I don't have to watch it, come. Please communicate better to the public. We're seeing a lot of stuff talked about, but no actions. And here we are still spending the money every single time. We have to have someone there. No, I do not want to go into the room 1 or room 2. Thank you very much. Thank you.
Any other public comment? All right, so we have a motion and a second. Mark?
I'd like to make a comment. So by adopting all of these, then we're gonna have to follow all of these.
Yeah.
Yeah, so we're gonna have to do a 10-year strategic spending plan. So I just want you to know that, yeah, these are what has been put out on the table, then we're gonna have to follow these.
It doesn't mean we have to follow their strategic
No,
10-year plan.
it
We can
doesn't,
make our own,
but-
but one should be made,
So
which makes sense.
then we have to, carve out, when we spend actuals, then we actually have to update the spending plan. So just want everyone to know that, yeah, this is a feel good, and yeah, we gotta do it. Well, there's a bunch of work in here we gotta do. So.
Wait.
Yeah, I'm too concerned that this is Lee Kemper's recommendation of key policies, and I'm not, it's the first time I've been asked to kind of adopt it, and I'd rather go back to the measure and make sure that these match up, and we're not adding things to the measure that wasn't originally voted on. But I do agree, we should, recommend some key policies. I'm just not sure if we jump on these right now the way they are, or we backtrack a little bit and compare them to the measure to make sure we're in line. And they're not just Lee Kemper's, ideas of what Measure B should be.
I think that's a prudent way to look at it.
Yeah, same comment. I mean, it's 3:30. We hardly, we've been doing this for 2.5 hours. And it was prefaced by, we should do something. We should show that we're acting. Well, I think sometimes you can't act until you get to the point where good action is before us. I think we've done a lot of good work today. We're going to have some things next time. This feels premature to, I'm saying what you're saying, to grab something right now, a half hour after we usually leave because we want to let the board know we're doing something, or the community know we are doing something. We are, but I think if we're going to do something, let's be sure, as you said, it's consistent with what we all want and what is consistent with the measure that we're, charged with following.
And my concern is we haven't addressed this specifically, and we've had very little public input and pre-advertisement. So if the public wanted to comment on this, unless they were here, they didn't get a chance to comment on it.
So the choices are either see if it passes or withdraw the motion. That's what I'm hearing. Or could we just move ahead?
Or we move ahead with a vote and find out if it passes or not, or withdraw the motion. And so the second or the maker of the motion could do it.
Yes on it, you probably should withdraw it, right? If
What's
you
that?
won't vote yes on it, I
I'll
will.
vote yes on it.
Oh, yeah?
Yeah, will you vote yes on it?
So, we have a motion and a second. Is there a discussion to withdraw the second or motion? Okay, Carmel?
I support this motion, though I have to say, I think that our auditor brings up a really good point, that our true charge is Measure B and what is written in that initiative. And so that's the only thing I would say, that we are certain that what's in Measure B and these guidelines do match. And that's the only thing I would say about voting on this today.
Yeah, I was just trying to, help the sheriff.
Yeah.
And say that we took some action.
You did good. You did really good. There's 11 of us.
I'm going to withdraw my second. I'm sorry.
You're gonna withdraw?
Okay,
Okay,
so
then I
we have a
withdraw the
second
motion.
withdrawn. Is there a second for Dan's motion?
I think it's a good.
No, I'm withdrawing the motion.
Oh, you've withdrawn the motion, okay.
Measure twice, cut once.
All right, so we're going to go through with committee member reports. You will be first now, Janine.
Okay, so I just wanted to, what I brought with me today, and I'll hand out, and there's some for the public, is what we call the data dashboard, and I think it's important for us to see it, so I will try to remember to bring it every meeting. This is given out to our Behavioral Health Advisory Board. It does let you know the number of clients we are serving, the number of clients that are being hospitalized, some of the dollars that are being spent. You have the 17-18 year-end report, in addition to the July 2018 report. So I just want to make sure everyone has a copy of that, and I'll put some on the back table.
Hey,
What I did this week was I participated in the NAMI Advocacy Day in Sacramento on Monday, where we visit legislators' offices and tell them what we're interested in, and we had really good response. They're in recess, so we just saw staff, but because they're in recess, they have lots of time to talk to us. So we talk about lots of things, but I always push, we need psychiatrists. Also, we have some books. For those of you who didn't check a book out last time, here's the book that I was trying to think. I'm not sick, I don't need help, that I recommend for people that haven't had any experience with people with mental illness and also living with a schizophrenic disorder, a personal journey. Anybody on the commission would answer? Oh, you're gonna pass it down? So yeah, fill out a library card if you're gonna check a book out, or Donna will get really mad. Also, we started our first family-to-family class, which she probably won't tell you, but it's a really beneficial class. Thank you.
Carmel?
I have a conflict in my schedule and may not be here next month. I'm going to try to get out of my prior commitment list, so I just want to let you know that. That's all I can think.
Doctor?
So what I've done recently is just a lot of robust discussions in advance of what we talked about today. I met with Lucretia Renteria from Mendocino Coast Clinics. They generated this letter that none of you probably read. It was sent this morning or last night. So basically, they feel that they need a crisis center of some type in Fort Bragg on the coast. They have some mental health services. They have a real issue on how to get patients from their facility to RQFC or to the emergency room. They've been kind of caught in a lurch. They're actually calling the police department. The police department goes, no, we're not a taxi. So it's basically, sorry, you're it. So they're trying to figure out how to deal with that. That was one of the first and foremost things that we mentioned. They're the ones that gave this the living room model. And I think it's something we're really talking about. It's a more of a peer treatment scenario. It's a less intrusive doctor-patient relationship. We were talking about the intensity of the emergency room, sitting there, being uncomfortable, not being treated. So I think it's something that would be beneficial for remote areas for sure, and it might be something beneficial for this area, because it could be more of a residential home rather than a hospital treatment thing. So I welcome you to read that and at least understand about it, and then, that might be something we want to talk about in the treatment aspect of things. One other thing, this was added to us, and I don't know if any of you read it. It was the Kemper Consulting Group. I guess this was a freebie.
What do you call it that?
Yeah, a freebie. But it basically was trying to justify the costs that were presented in the original Kemper report. They provided a report that has to do with the market rate of housing in California and the prevailing wages that were associated with prevailing wage housing markets. Well, those don't really apply to what we're doing here, but one thing that there is a definite flaw in is the rates that they used. The rate they used for an electrician was $51 an hour, I believe. Prevailing wage rate for an electrician, $43 an hour. So here's the actual prevailing wage rates, and I will pass these around. And this is what the employee gets paid, and it's under, sorry, you need two copies, so why don't you send them back around. But the actual prevailing wage rate for an electrician is $71.52 an hour, and that's what the employee gets paid. So, and that doesn't include the burden, the liability insurance, and everything else that goes along with that. Plumbers, the plumber rate is $114.44 an hour. So it's a big thing, and it's something that we're mandated by. So I just want you to, then this information is easily obtained at the Department of Industrial Relations. So if you want to look and verify these yourself, you're welcome to. But that being said, getting into it, it would be very helpful when we go to fund
to have a qualified estimate when we bid, or when we fund it. That's all I need to say.
It's a really big difference between what Kemper originally estimated with and what the real numbers are. This is a huge delta.
Yeah, so for me, I continue to reach out to the community. We'll be going to Willett City Council tonight to report as best I can on all that we covered and answer questions. And I too, just a heads up, I may not be here at the next meeting. I have a family member in the hospital and I may be attending.
Dennis? I have nothing to report.
Me either.
All right, so October 24th at 1 PM in this meeting, in this room is our next meeting. Thank you very much for attending.